Welcome to this week's live Q&A with Professor David Jones and a returned welcome of Collette.
Okay, thank you, Jacqueline. Hello, everybody. Welcome, Professor David Jones. Lovely to be working with you again.
It's like Back to the Future, isn't it? We need it
Back to the Future. And you and I are looking so much younger than we did. How wonderful.
Yeah, no.
Hello, everybody. Welcome to today's question time. Before we start, I would just like to say to you, it's the first time in a long time I've read through these questions. Now, these are not private consultations. Some of these questions are extensive and they're personal. We cannot answer personal medical questions for lots of reasons, but mostly legal, because we don't have all the information about you. And if Professor Jones was to attempt to answer some of these larger questions, he's only doing it on the basis of the information we have here. There could be a lot more information needed and valuable. Something could be said, or it could be completely and totally wrong. That puts him at risk, and it certainly puts the foundation at risk, and it puts you at risk. So please keep your questions. They're general. We'll do everything we can to answer them. But personal consultations, we can't do that. What we can do, because I'm still running the helplines, if you have convoluted questions, the office will get a hold of me. I'll phone you. We can go through it. I can help you word something for your consultant. I can help and direct you. I can do that, and then narrow any question down. You can bring it to our medical advisors. So I think is that okay, David? Are you happy with that?
Yes, yeah. So what we can do and have always do is kind of use some of the questions to make broader points that are interesting and relevant. And I filter that a little bit. So sometimes people want to talk about something which, in all honesty, isn't really related to the PBC. So, but over the years, the years we've been doing this, and it's difficult to imagine that Collette and I have been doing this for years. I mean, we look so impossibly young and vigorous.
Incredibly so.
And so, yes. It's the extent to which the questions that asked are generally resonant, and I think that's been one of the things that we've really found very useful, is to use somebody's experience and then broaden it out, to be of interest to people. So this is designed to inform for sure, but also entertain a little bit. With that caveat, just to say that Robert and Mo are not around because they are currently mid-Atlantic, flying back from the American Liver meeting, which is what I did yesterday. So I've literally been chain drinking coffee to still be awake. I'm slightly wired up. So if I get a little jittery, that's the coffee hitting.
Okay, coffee has been indigestion, it's PBC. And for the points of it, any new people in the room, and welcome to everybody. Well, Celia. Hi, Celia. I've had PBC now 30 years, so I know a little bit about it. Right.
Well, I first saw somebody in a PBC clinic. I first did a PBC clinic in 1991.
Right.
I just thought I'd mention that.
Wow.
It was when and I don't know you find that difficult to believe, everybody, but I mean, this was part of my primary school, medical program, because I'm obviously not old enough to do that.
As a boy, you knew what you wanted to do. That was it.
Yes, just a little bit. One of the things that I will weave into this is what's new and what's come out in the last few weeks and months. There's a lot going on.
Okay.
And a lot going on at the American Liver meeting. So what I will do, there will be a what's new and what's hot bit in the bare facts at some point. But I will tell you if it's something which is kind of new, which is coming out. And the newest thing is, which I don't think anybody will know actually, is that the GSK trial, the GLISTEN trial of a drug called Linerixibat.
Oh, of course, remember you know in Stevenage,
well, absolutely. So Collette and I were there at the very beginning of that program. They've just done the phase 3 trial, which is positive. So the drug works for itch.
That was 10 years ago, David. 10 years ago.
Yeah. Wow, 10 years. Well, but the point is, that's what they always say. It takes 10 years from a good idea to a drug. Anyway, so that's really important. So the Linerixibat trial, this is the first drug designed specifically for itch management, as opposed to it being a bonus on the side. So that trial is nicely positive. That means I suspect that it will go through what we call regulation, so it will go through approval, and I think it will become not just yet, but I think it will become a therapy that is then available in the clinic. So PBC, to do with the efforts of everybody, all the patients, and I think the doctors and the companies as well, we have an extraordinary track record of drugs being effective, and I think you look at a number of disease areas that they really struggle to find any drug, and I think this will be the 5th licensed drug in PBC, which is extraordinary.
We were there to persuade them to carry on with the research, and if I remember, there was one patient had been transplanted for the itch, another was waiting, was desperate with it, and the audience, and there were overseas at the desktops, they were in tears listening. But just further to that, when I was first diagnosed, there was no URSO. So think about how far we come. But I tell you, the people, our medical advisory and our members are really changing the landscape. So well done, Robert, bringing all this about, and the team, they're just marvellous. So you're there. Right, David, I keep mark you out of 10, okay?
Can I just tell you, by the way, sorry, that you and Robert are not a patch on Mo for telling me off. I mean, it's like being at school again. I mean, I get told to shut up and move on. You don't see it.
No, I would never do. I've got nice ways to do that. Right, question number 1.
Yes.
Any problem with taking NMN or multivitamin drinks that contain Thain and MNN together? I don't know what either of these things are.
Sorry,
I-C-9 and NMN.
NMN. I'm not sure what that refers to. I will look.
Well, the person's watching. Drop Jacqueline an email just now, or I'll put something on Facebook, and we can come back to that.
Right. No, sorry, it's nicotinamide mononucleotide. Fine, that's all right.
All right.
It's just an abbreviation I'm not familiar with.
Right.
So, no problem at all. Vitamins and supplements is something that people ask about all the time, and there are undoubtedly some vitamin deficiencies that PBC patients get. In the old days, we see a lot of vitamin A and vitamin D deficiency. Those are fat soluble, as part of the role that bile acids play in absorbing fat. The other one that we see is antioxidants that normally sort of take away the free radicals that cause a lot of injury. Those are a little bit depleted in PBC, and so actually we suggest a good multivitamin, a broad-based one, is a good idea for people to take. Coenzyme Q10, a number of people take. Nicotinamide, NMN, is it's one of the energy, the molecules your body needs to generate energy. Okay, so it's not energy itself, but it's the sorts of things your body needs to convert food to energy, and those are the sorts of things that are depleted in PBC for whatever reason. So no problem with that at all. Excellent. People ask, why don't we do trials of these things? The answer is it's very difficult, because these are things people take in their diet as well. But there's also, whereas if you want to, I was talking about the GSK drug, if you want to do a drug trial, the rules are very clear about what you do and how you do it all. But for food supplements, the rules are very grey indeed. So it's strangely easier to do a trial of a drug than it is of a food stuff or a food supplement like that. So it's just one of those oddities of life.
As long as you know that it doesn't do any harm, that's amazing. Right. Okay, is a high HDL of 152 part of PBC? Should I be concerned about this being so high?
So, cholesterol is a perennial question in PBC, for the simple reason that abnormality in cholesterol is a sort of integral part of PBC. If you go back to the very original description of PBC from 1853,
even I'm not that old, David.
No, quite. So our old friend Thomas Addison, who was the father of autoimmunity, described Addison's disease as well, that many people have heard of. And William Gull, who was his medical student, who went on to be Jack the Ripper, but that's a whole different story.
Stop it, get back to this.
Yes, so their original description, it's extraordinary. Their original description, if anybody's interested, I've got a copy of it in his book. And I might do a photocopy of it if anybody's ever interested, so they can just download it. So they didn't have a clue what was going on, but it's what we now describe as, we know as PBC. It wasn't called that then. And it's in those days, they were very good at describing things. They didn't really understand the disease or what was happening, but they described it in detail. And the description is extraordinary. I mean, it's absolutely what we would now describe as PBC. They describe itch and fatigue. We managed to forget about fatigue as doctors until about 170 years later. But they describe all of that. But the image, they've got a picture, a painted image of the patient, and she's got fat deposits around her eyes, which is what we used to see in the old days.
Yeah, we used to see that quite a lot years ago before our
But we never see that now, and I think that's an Urso effect, if I'm honest. But there you go. Anyway, so cholesterol, total cholesterol, is almost always elevated in PBC, but the meaning of a total cholesterol number is lost in PBC. So when you go to your doctor, they'll measure your total cholesterol and they'll give you a number, and that number you'll go and then look up. But just be very careful, because those numbers are usually elevated in PBC, but it is not as important as it is outside PBC. Why is it not important? Because it's not the total cholesterol that gives you heart disease risk. It is one fraction of it, the low density variation of it. And the other half of your total cholesterol is the high density part of it, high density lipoprotein, or HDL. Okay, so you have total cholesterol as high density and low density. It's the low density that gives you heart disease. The high density form is actually protective against heart disease, okay, because it's carrying cholesterol back from the vessels where it could cause injury back to the liver. So it's that bit that's elevated. So actually the total cholesterol for most PBC patients is elevated because the good stuff is high, not the bad stuff. So therefore, not only is there not any problem, it's actually a beneficial state. Now, the caveat to that is that the reason why your low density bit is elevated, it's nothing to do with what you eat. That's an urban myth. It's to do with your genes, which you inherited from your parents. And so having PBC doesn't stop you also having an elevation of the low density bit. You're not more likely to have it or less likely to have it, but PBC doesn't protect you. So it is possible to have an elevation of that one as well as a high density one. So what we do in the clinic is we measure the high and low density version. So we measure what we call a split cholesterol. So we measure those two. We make a decision about treating cholesterol based on the low density component. So a high density cholesterol at that level is absolutely fine. It's not associated with heart disease. It is associated with actually heart protection, and it's typical. And remember, at the end of the day with PBC, heart disease is actually very uncommon. So, that was always the oddity, that the cholesterol was elevated and yet people had a very low risk of heart disease. But remember, PBC fundamentally doesn't stop you also having the family version of high cholesterol. So it just needs a little bit of extra thought. Now, one of the things that we're going to talk a lot about is increasingly is what you do about cholesterol that does need treating in PBC. So if you do have a heart disease history, I've said it's no more common in PBC patients, but it's common in the population, so we'll still see it. So what happens if your doctor says you need to take a statin for your heart protection? And one of the issues we've always had with PBC, particularly with second-line therapy, is interactions between bezafibrate and statins. And one of the really big changes that's going to come along is the advent of the drug elafibranor, which we've talked about in these sessions before. This is now fully approved in the UK. So we have 2 second-line treatments in PBC, obeticholic acid and elafibranor. Elafibranor is now fully available. It's approved by NICE. It is in the clinic. We are now starting to write prescriptions for it. And the important thing is that's the drug that you can take with statins if you need them. So the world is going to get a lot easier because that drug allows you to do it. Now, Collette, can I do a shameless plug at this point?
Hurry up.
Right, my shameless plug, okay, is this is the 3rd edition of my book, okay?
Is my forward in there?
No. This is the 3rd, so people are familiar with the book, right? This is the 3rd edition. Mo and Robert have the only other edition, the one in existence, but it's now available. It's on Amazon, and that goes into all of the stuff about which of the second-line drugs to use when, which of the different ones are useful. Because I'm very aware we've updated it for the simple reason that it's now, the field has got very complicated with all the new drugs. So this goes into which drugs, combinations of drugs, which one to use in which person, what to ask your doctor about. So it's been updated deliberately to take account of all the stuff.
Well, that really answers the next question. Please could you ask your thoughts and stuff.
So it's available on Amazon if you want to buy it.
It's on Amazon, everybody, and he does donate to the foundation from the sales of the book. Okay, so the next question is about your thoughts on taking statins. Clearly, you do prescribe statins. What I would say to anybody taking statins, read the leaflet. Yeah. Read the leaflet in the packet because there are side effects you may not associate with your medication, and they won't necessarily stop when you take the medication. So please read the leaflet, okay?
Just a quick comment on statins. It is a bit of a British obsession, giving statins out. You talk to our European and American colleagues, and they're not nearly so widely used. And it's just worth knowing that. They are like all drugs. They are useful where they're useful, but they're not a miracle drug. And it's important to bear that in mind. I come across people who are made to feel guilty because they can't take them, and that's nonsense. So this is important. There are 3 reasons why anybody might be given a statin. The first, and it's the 3rd one, which is the common one. So the first one is you have what's called familial hypercholesterolemia. So this is a very rare condition where you are genetically have ridiculously high cholesterol levels. And these were families where people were dying of heart disease in their 20s and 30s. And statins in that situation are literally life-saving. So if there's a very strong family history of heart disease, then that should have been looked for. And if you do have familial hypercholesterolemia, which is not related to PBC, but it's a reason to use statins, then statins are the treatment, and they are literally life-saving. But that is tiny numbers of people. The second reason that statins are used are in what we call secondary prevention. So if you've had a heart attack or a stroke or had angina, then you've identified yourself as having a heart that's at risk. And statins are universally used in that situation. And that is also very strong evidence support for it. Okay. So in that situation, again, you'd be very sensible to take them because they are protective. It's the third group that's more problematic. And these are people where the GP's done a formula which looks at your age and your family history and your blood pressure. You'll all be familiar with them tapping this information in the surgery. And they say you've got a greater than 10% 10-year risk of heart disease. You should take a statin. And that is much grayer, is my point. Yeah. This is where Colette's comment is so important. In that situation, you need 10,000 people to show they're beneficial, not a handful. Yeah. And so there are then pros and cons. So the cons are the same, but the pros are much less. Yeah. And in that situation, it's about you and your individual risk and benefit. So statistically, they are useful, but you'd have to treat a lot of people to know if they are. But if you're getting nausea or you're getting muscle pain directly from them, it's not worth it. No. So that's where you need to do it. And I think sometimes people
using another kind of statin wouldn't necessarily avoid these.
So sometimes we get a little bit of guilt you need to take the statin because the rules say you should. No, it's not like that.
Yeah.
They should be considered and the pros and cons discussed and a decision reached that is the right one for you. And we have seen a bit of a trend of people just being sent statin prescriptions to the pharmacist and told to pick it up without any clinician talking to them about it, which I don't think is the right thing.
Age thing. Yeah. Right, I'm going to keep moving. So here's that. I'm going to answer this one. I've recently been diagnosed with PBC, but not yet started urso. Any tips? Yes, get some.
Start urso.
Push for it. Push for it. Tell them Collette said. Your GP cannot prescribe them, but you can go directly. You can drop a wee email to your consultant, the person who's treating you, and if you're not sure how to word that email, give me a shout and I'll help you do that. Yeah.
GPs can prescribe it.
Well, they can. No, but they need the instruction if you're newly diagnosed from the consultant.
So basically, if you've just been diagnosed with PBC, everybody starts urso, full stop. Take it at 13 to 15 milligrams per kilogram. The PBC Foundation has a very useful calculator,
we do,
which Collette will shortly wave to help work out the exact dose. And basically that urso, there you go. What's your urso dose?
It's in pounds and kilos, old money, new money, and they're free if you contact the foundation. And we have them
and basically think of the urso as being lifelong. It's very well tolerated, but everybody should start it. And then there is another question then about whether you need anything else on top of it, but you can't answer that question until you've started the urso. So, and sometimes, I mean, I was talking to some people in America, and they see people in the clinic and they talk to them about PBC, and then they check all the tests and check it's PBC, and then they see them back, and then they talk about urso, and then they come back, and then they start it. When people come and see us in the clinic, they leave the clinic on day one with a prescription. I mean, why wait? Okay. And psychologically, that's very important because we're straight in there, right? The fight back starts here. So you know, if you're confident in the diagnosis based on the GP tests, just start it because everything else flows on from that.
What we have is I have Hashimoto's as well as PBC. My question is my cholesterol 7.2, triglycerides 197, HDL, Is this related to PBC and Hashimoto's? I'm not on statins and don't have any comorbidities. Well, I think we've covered everything.
Yes.
From the previous question. So
it's not Hashimoto's. So Hashimoto's is thyroid thyroid deficiency, okay? And that's not associated with high cholesterol. It's a PBC thing.
So I think we've kind of covered that. So now this person is asked, please could you guide me whether you think I should be exploring the pathway for PBC with a possible overlap of autoimmune hepatitis as I've been tested high weight positive for anti-smooth milk. Now this goes on, this is a very lengthy, there's about 5-6 paragraphs. This is the kind of thing that I was referring to earlier on. A lot of information here is personal information, but you know, so two of the questions I think are important. Should I be reassured if a CT comes back normal, or should I be requesting a biopsy? Nobody should be requesting a biopsy. That's up to a consultant to discuss it with you. But I would say to this person, call me. Let me talk you through quite a few of these things. I'm not a doctor, but this is not for today's question and answer. It's unfair to ask Professor Jones to comment when he doesn't have a whole story.
I'll just give you a quick comment on overlap, because this is a topic that comes up very frequently. By this, we're talking about the possibility of PBC also existing with autoimmune hepatitis, which is the yang to the yin of PBC. So it's the other autoimmune liver disease. So they are they're different because the cells in the liver that are targeted by the immune response are different, but they're first cousins, if you like. And they're very easy to distinguish in practice. There's never any confusion between them. The issue is, in the past, there was a feeling that some people had both. And in particular, there were people who clearly had PBC because they had the AMA and the blood tests and the symptoms, also had some blood tests that made people think about autoimmune hepatitis. Okay. Now, this is an area where there's been a lot of changed thinking. If only there was a book out there that went into this in real detail.
If only. Try Amazon, folks.
Yeah. So So the reason this is really important is that we think that overlap does exist. There are people who have both, but we think it's vastly less common than it was used to be thought to be the case. Yeah. So it still do see it, but most of those people who were thought to have it but don't have it, in fact, have the newer variants of PBC that we recognize. So the blood tests that made people think of autoimmune hepatitis also improve with the second line therapies in PBC, like obeticholic acid and bezafibrate and elafibranor and seladelpar. Okay, so in fact, that it's not autoimmune hepatitis, it's just a different version of PBC, often in people who didn't respond to urso. So this has become much less of a problem as we understand that, and those treatments are effective. The thing to be really aware of, though, is there are a lot of people out there who are still taking steroids because they were thought to have autoimmune hepatitis. Now, steroids do not work in PBC, and they don't particularly work. And there are lots of people out there who haven't really responded to steroids, but they're still taking them. Now, nobody listening to this should stop taking steroids they've been taking for a long time. Absolutely not.
No, they've got to.
Your body misses them, and it's a dangerous thing to do.
Yeah.
But if you have got a label of overlap, then you should go, and next time you see your doctor, say, do I really have overlap, or is this just my PBC? So what they can do is go back to the original biopsy, and if that's not been reviewed, it needs to be reviewed. Doesn't mean you need another biopsy. They can go back to the original one and reinterpret in the light of what we know now. It's about 80% of those people, actually, it's just PBC, and 20%, is overlap. And I saw a lady a few years ago who had been on high dose steroids for 20 years and normalized her blood tests on urso and bezafibrate. And she's really happy, but is a little that she felt she'd been on steroids she didn't need for 20 years. And she was right. Okay.
I would understand that. Okay. So, the next question, how are you on midriffs?
Look, I have nothing sensible to say about midriffs at all. If you can see my midriff, which you don't want to,
and then I'm coming to the screen question. So the midriff, about 10 days, 2 weeks, full feeling like something's moving around the midriff, very uncomfortable. I've taken bicarbonate soda, hot water, milk and magnesia, got some relief with Andrew's liver salts, not pain, just discomfort, and it feels like something's moving in the midriff and worrying. Yeah,
so your guts move all the time, okay? So they wriggle like a worm. Now, most of the time you're not aware of that, but you can become aware of that. And you become aware of it in two situations. One is if they're moving more, so you're aware of it because there's more of it. And then the other is because you're aware of it because you've become tuned into it and aware of it. And tuning in and out of body's sensations is actually something we're very familiar with in the setting of itch, because many people on the call will be familiar with, getting to the end of the day and thinking, gosh, I haven't noticed my itch today. And that's because their brain has tuned out of it. Another one people often talk about is hearing your heartbeat. Okay, so most of the time you don't hear your heartbeat, but you can lie in bed at night and hear your heartbeat, and you think, is my heart abnormal because I can hear my heartbeat? So your brain tunes in and out of body sensations. So
left side of midriff, what would have caused this? And if bicarb is helping a bit,
so what I suspect is that is just hypermobility. So that is actually the bowels moving more, and we do see this with they're wriggling away more. I mean, there's no two ways to describe it other than bowels.
Are your bowels as high up as your midriff, are they?
Yes. Yeah, they're under your This is
well, I'm an
under your diaphragm. So yes. So it's actually the small bowel that normally does this. So the small bowel is more motile, and we do see this in PBC as part of the. I was getting around to the point. We do see this in PBC as part of the kind of urso side effect profile. So bowels tend to be hypermobile in PBC because that's what bile acids do. And urso can cause that in people. So, and bicarbonate just reduces the amount of acid, which is one of the things that will trigger it. So there's some logic to that. What I would suggest is if this is somebody on urso, okay, then it falls into the spectrum of urso side effects. And it's sometimes useful to split the dose of urso in those situations.
All right, okay.
We tend to suggest to people to take urso last thing at night or in the evening altogether. And we do that apart from when it's sensible to try other ways of doing it. So sometimes if you are getting that irritation, nausea would do it. Same with nausea, same with sickliness, diarrhea with urso. Just try splitting the dose, taking it during the course of the day in smaller doses, or maybe dropping the dose back, getting and building it up very slowly. So I suspect that the wriggling is the gut. I suspect it's the sort of gut hypermobility that we do see in PBC.
Could this be a stress thing as well?
Yeah, and then just try fiddling around with the urso dose would be my suggestion.
David, do you remember when we were in Easel 2 years ago and I sat with you on stage with 3 other specialists? And next to me, there was an Italian lady. She was a professor, gastroenterologist. And this came up as we were chatting for reasons I can't remember. And she had said to me, one of the myths, and I hope everybody's listening, one of the myths about gut stuff, she says, do not take peppermint. I said to her, I take peppermint capsules. She says, do they help us? I said, I don't know. But it hasn't gone away. She said, don't take, and she was right. She was right. So
Collette, of the reminder of the things that you don't do, because we haven't had this since you've stopped doing these things, what's the other thing you shouldn't do ever? Mouthwash.
Oh, absolutely, mouthwash. Never. It stains your teeth. It's addictive. And it destroys the taste in your mouth. Never. And check with your dentist and just say, Collette told me. James Newberger checked with his dentist and he said the lady's right.
Yeah, and people and it used to be a standing joke with Collette and myself. She always used to say it, and it's right. And I thought, therefore, just for old time's sake, we'd reintroduce it. You've forgotten about that, haven't you? And the point is, a lot of people do use mouthwash because of the dry mouth effect that they get. But what it does do is it actually causes damage to the teeth and affects the taste. So in fact, if you want to switch around
dry mouth
and toothpaste, you know,
it doesn't help dry mouth syndrome either.
No, exactly. Yeah.
So we've got another. I'm going to do this on the screen actually. Is it okay to take naproxen 250 milligrams a day and diazepam with urso? However, currently not taking PBC meds, so is it still okay to take given for muscle spasms? Why aren't you taking your PBC meds? That's not allowed without good reason. A note from your mum. But naproxen is obviously a pain relief. But diazepam Valium is a muscle relaxant, and I occasionally have to take it with my bad back with her.
Yeah.
So naproxen, David.
Yeah. So right. So I'll just take those in turn. So I'm with Collette. Please do try and take your PBC meds because pain is uncomfortable. You know, muscle spasms are uncomfortable, but PBC is a condition that can shorten your life. So that, in a sense, it may seem like the lesser of things, but actually it's important to do that. I mean, diazepam is used in 2 situations, one of which you shouldn't use it anymore. So the situation in which you should use it is for muscle spasms, where it's quite useful. So back, there are situations with other ones. There are other medicines you can do, but diazepam is quite useful for that. The situation it shouldn't be used in is for anxiety, which is what used to happen a lot, the sort of tranquilizer bit of it. And the reason it's not healthy to take it is it's addictive in that setting.
5 days of Valium, apparently you're addicted.
Yeah, it can get addictive and it loses its effect, and then it has a hangover effect. Now, that was an issue. I mean, I can't remember the last time I saw somebody who'd had it started. So it's not something GPs are doing these days. It's important. It's important that because anxiety is common in PBC patients. So there's a lot of research out now about anxiety a little bit about depression, which is a little bit of an issue, but people do seem to have quite a high level of anxiety. And I think it's about worry for the future and fear and all of those things. Now, we talk about this very openly in the clinic, and anybody who's come to see me will know that we have open conversations about how people can feel and how things can sometimes get on top of them and all of that. If people normally talking about it is the best way to deal with it, and having very open conversations with family members, and if we can broker that, that's very useful. If people it's really getting on top of them and it can be horrible, then we tend to use sertraline in that situation. That's when sertraline is quite useful. So we would use sertraline rather than diazepam. Diazepam masks the problem. Sertraline allows you to kind of get a grip of it, and then you can get a perspective on it. So that's what we would tend to do. Just on the note of, I mentioned about the linerixibat trial. Collette reminded me correctly of us all going down to persuade GSK to do this trial, and they were astonished by the nature of the impact of itch on people, because they hadn't heard this and weren't familiar with it. Anyway, the trials have gone on and ended up with the press release 2 days ago, the trial working. But the other thing that we've done with GSK is to take the stories of the people involved in the trial and the way in which the itch was affecting them, and to really understand it. And that paper coincidentally was accepted yesterday. And I think that would be a very important piece of work, because it really does show how bad the itch can be. And it's the antidote to the sort of, oh, that's not a big problem, you all get some itch sort of thing that people sometimes get. So itch is really important in PBC. It's a really important target for treatment. And the good news is that there are effective treatments we can always do with more options, but nobody with PBC should be troubled by their itch. There are enough therapies out there to do it. So if somebody says, oh, itch, that's not a big deal, and it is a big deal, then push that point. The data are now out there. Sorry, going back to the question, naproxen. So naproxen is a non-steroidal anti-inflammatory drug. So it's one of the family of Brufen. It's a more potent one in that family. There are a variety of different sort of potencies. So it's one that you only get on prescription. And it's quite a powerful anti-inflammatory drug. Now, there is an urban myth out there, and if anybody knows where this comes from, I don't know, but I keep being told this, that people are told by their GPs they can't take Brufen because they've got PBC. And there is no evidence of that whatsoever.
I know quite a few hepatologists who are very, very cautious, including my own, very cautious, to the point they'll say to you to use the cream if need be, the ibuprofen cream, other than take the tablets.
I mean, I'm not sure what the evidence for it is. I've never seen it. Now, Brufen has side effects. It causes stomach irritation and all of those things, but that's no different in PBC patients to other people. So, but these are very useful drugs if people have got pain. So naproxen, the rule of thumb with non-steroidals is that the more powerful the drug, the more the side effects. So naproxen's about 3 times as effective as Brufen, but it's also 3 times as likely to give you those gut side effects. So it's not a drug we would use commonly, but it's fine to take it. I mean, and if you're taking naproxen together with diazepam for muscle spasms, it sounds like you've actually got probably back pain, significant back pain, which is causing those things. And so there's a logic behind it. Neither of those is a problem with PBC, but I would avoid those drugs unless you really need them, because they're both drugs that have kind of a different side to them. But remember, there's a theme coming out, isn't it? All drugs have things that are good and all drugs have downsides, and it's always in everybody the balance between the good side and the bad side, which is a dialogue to have.
Because this person's saying that they're not taking their PBC meds. So I'm wondering if they're worrying about their URSO interacting, or they've got symptoms from what might be the naproxen that they're blaming the PBC meds on. So down to that person, maybe if you want to give me a ring or get back in your meds.
So the general point from this one, so just on that in general, urso doesn't really interact with anything other than
We're very lucky in
cholestyramine.
that regard, David. Very lucky.
Yes. So cholestyramine, Questran, that delightful treatment that so many people enjoy for controlling their itch, which we use very little of these days. That will bind the urso. That will bind the urso, and you can lose the effect of the urso. It's not harmful; you just lose the benefit. But the other one that Questran can bind to, of course, is obeticholic acid, which is a bile acid. So please, if you're taking Questran and obeticholic acid, space them out by at least 4 hours. If not, all that very expensive obeticholic acid goes into the toilet, and that's not good. And you lose the benefit of it. So no interactions, and generally speaking, drugs, PBC and drugs is not a problem area. There's some conditions where you've got to be cautious about lots of different drugs. We're quite fortunate, as Collette said in this, that we don't have a lot of those, and your doctor should think about them anyway. And pharmacists actually have registries now, so when they're dispensing prescriptions, they should check against, but it's very rarely.
That's the point. Pharmacists in this country are highly qualified people. They're underused. Don't hesitate to contact them, and if they don't know, they know where to get the answer. I'm coming back to you, David, not taking meds because of gastro issues that urso may be affecting. So I'm right. I think that I should maybe talk to this person. Get them
that will be the naproxen, okay?
Yeah,
that will be the naproxen. So what you need in that situation is something for stomach protection from the naproxen to allow you to take the urso. That would be, but that's the naproxen. That's what naproxen does.
Yeah. So they do it's something like omeprazole or something.
Yeah, exactly. I'd go for omeprazole.
Okay. Just as you mentioned itch, I just want to give some tips out, and you can keep this for your clinic and your staff as well. I hear a lot on the phone and have done over the years, as you have done as well, young man. And you listen to people, and if it works for them, you pass it on. 3 things. And I know the nurses do this at our local hospital, our liver unit here. If the itch is really bad and it comes at night, we all know this, it's worse at night. So if you get Epsom salts, you buy big bags at the chemist, bath in Epsom salts if you have a bath. You can do that. Calms down the skin. Here's another one for you. Instead of using soap when you're washing, Vosine. Dandruff shampoo. I've had that a few times on the phone.
That's a new one on me.
Vosine.
Yeah.
Old dog and all that. And another thing that's been said to me repeatedly, particularly as it's coming up Christmas, chocolate. Now, I don't know if it's sugar, but chocolate is an instigator for some people with the itch. People have given it up, it's not Christmas time, be chocolate orange or whatever, and the itch has come back. So there is something for you to think about.
Can I add to that? So the two I've heard, and again, all of these things are from more than, from numbers of people. So. So one is orange juice making the itch worse. Okay.
Again, we'll look at sugar, right? Okay.
So orange juice making the itch worse, and this is not to say stop drinking orange juice, but if you go away and think, oh, now hang on a second,
just hang on, be mindful.
It's not crazy. This is something people have reported. And the other one in terms of benefit is vitamin E bath oil. Now there was a vogue for that a few years ago. But I'm not sure if it's available. It used to be a Holland and Barrett type of thing. But a lot of people used to add some vitamin E lotion into the bath, and that used to help. Well, I guess I'm saying as we come up to Christmas, if chocolate makes the itch worse and orange makes the itch worse, so no chocolate oranges for you lot then.
Do you know, I'm one of the few people you'll ever meet in your life, I can't stand chocolate, sugar of any kind. I hate it. I remember you riding wheels years ago.
My kids will be traumatized because they can chain eat chocolate oranges at Christmas.
Right, I'm going to keep having them.
On a simple note, right? This is on an important note, right? There are things that make it worse and better in individuals, and there will be some things that are common across other people, and some things will be just you, right? It does not matter what makes your itch better. If it makes your itch better, it makes your itch better, right? So it doesn't matter whether anybody else has heard of it and nobody else has heard of it. Not if somebody is trying to sell you something that's expensive, but if you've just noticed something in your life and avoiding it makes your itch better, it's made your itch better.
Yeah.
Now, it's not, when you're looking at the disease itself and controlling the disease, you have to be careful about whether it's really working or not. But for a symptom, if you don't have the symptom anymore, it's really working, isn't it?
And pass the tip on to us.
And pass the tip on to us. Absolutely. I say that to people in the clinic all the time. We're kind of, so much of what we say to people is what we have been told by people over the years. And again, I sometimes get people say, oh, I'm sure I'm wasting your time coming to the clinic. Well, absolutely not. That's what we're there for. It's what we do. But I also say that every single person I talk to with PBC, I learn from. I learn from their experience, and then I cook all that information up and I pass it on to the next people.
Do you know what I learned quite recently? They think I'm the first PBC patient in the United Kingdom that wasn't diagnosed via a biopsy.
Is that right?
So I suggest you start thinking of some kind of medal that I could wear.
That would be about right, actually. It would be about right. I mean,
this lady says, I do take omeprazole, was being tested for BAM, asked, can I go back on urso, got told to hang fire. Naproxen has been issued afterwards, cause of another condition. I do take it, was being tested for BAM. I don't know what BAM is. I'm going to leave that because I tell you, we're running out of time. If you can give us more, then fine, but we need to crack on. We're doing what we usually do. Now, quick fire. Is PBC more aggressive in men than in women?
Right. Sorry, can I just go back one?
I can't control you. Do you know that?
Robert back, weren't they?
How many screens have you got?
What?
You've got 2 screens there, haven't you?
Yeah, no, okay. Right. Everyone will be wanting
biliary acid disease.
She tells me.
Biliary acid disease. Biliary acid disease.
I thought you were going to say bile acid malabsorption.
I think we're going to leave that one. I'll get more information.
I think it's bile acid malabsorption.
Right, okay.
In which case it is URSO related. So URSO will drive that and make it worse. So the comments about that. Just in general with omeprazole, it's one of the drugs where escalating the dose is effective. So if anybody's getting really bad reflux on 20 milligrams of omeprazole, then it is a drug you can increase the dose of.
Could this person take second line bisphosphonates or?
Oh, yes.
Sorry?
Collette makes a very good point indeed, which I will just expand on. Deep breath. Right. So URSO is standard. Goes back to the question about should I go on to URSO? Yes, everyone should take URSO. However, about 1 in 20 people won't be able to tolerate URSO. Okay. And it's usually these sorts of GI things. So it's nausea, it's sickliness, vomiting occasionally, wriggling guts, loose bowels. And you stop the URSO and those all go away. And then you start it again. They come back because it's the URSO, the bile acid nature of URSO that causes that. Now, what do you do in that situation? Well, first thing we would do is do what I've said before, which is to sort of split the dose and to start at a much lower dose so the body gets used to it. So drip it in. You're wanting to get onto URSO for lifelong treatment. So you'd want to just drip it in. So start at a lower dose and split the dose. There are, however, some people who even doing that just can't take URSO. And in those situations, what you do in 2024 is give people one of the other drugs. So the drugs that I've mentioned, obeticholic acid, elafibranor, seladelpar, probably not bezafibrate in this situation. Okay. The other 3 drugs, which are the licensed drugs, are all drugs to give where your response to URSO is not enough, but they also have a secondary use in people who can't tolerate URSO as an alternative. So we have lots of people on these drugs because they need them because the URSO isn't working. We have a much smaller group of people who take them because they can't take URSO. So for somebody who's having a bile acid effect or getting the GI disturbance and they can't take URSO, they should be having a discussion about taking one of the other drugs because now that's fully recognized. It's part of their use. And that's a very good point that Collette made.
Right. Okay.
That there are now alternatives, and you shouldn't just have the Urso in a bathroom cabinet.
So
You should
come back
else.
to me, Sally, and let me know how you get on. You'll get my number from the office. And right, I'm really going to fire these. Is PBC more aggressive in men than women?
PBC is different in men and women. It is less likely to respond to Urso, okay, but it's also less likely to be symptomatic. And we see more people with cirrhosis who are men than women, but that's probably because the diagnosis is made later. So provided it is diagnosed and treated and responding to treatment, it's not different other than a little less symptomatic. But I'm afraid doctors make assumptions about liver disease being caused by alcohol. I'm afraid that means that PBC often gets missed.
Okay, thank you. So this is from a middle-aged man. Again, it's one of those questions. It's quite personal. He starts by saying, I'm currently waiting for tertiary centre approval, which I've been asked for by my general hospital. Thanks to the previous advice, Dr. Jones and PBC Foundation. Thank you both. So you're very welcome. So he's put some details in here. He's asking whether you should have elafibranor or OCA. I don't think it's fair to ask you this question. I think this has to go to your own consultant, whoever you are, young man. And if you want to give me more detail, you can phone me and I can help you put something together. But it would be unfair to present Professor Jones.
Can I do a general comment about it all?
You can do a general, only general, yes.
Other than
I'm saving you from being sued.
Yeah, I know. Other than my book goes into this in detail, that's shameless, right? Okay, so we've in the UK right now we have 3 second-line therapies available: obeticholic acid, which people are very familiar with; elafibranor, which people are less familiar with, and then we have bezafibrate, which is a repurposed older drug. Okay, now in 2024 we would not typically be starting people on bezafibrate as a standalone second-line therapy. Why? Because we've got 2 licensed drugs that we should be using first, which we understand better. Now, does that mean I would stop somebody on bezafibrate? No, absolutely not. If you're on it and it's working for you and you're tolerating it fine, it's working for you.
Provided you're having kidney function tests, though.
Yeah, exactly. And that includes having your kidney function test checked. So if it's working for you and it's fine, don't go changing. So this is about people starting on things, right?
Yeah.
Of the 2, obeticholic acid and elafibranor each have strengths and weaknesses. They both clearly work. Not going to go into them in detail. The one thing I would do is if you have itch, then probably I would go down the elafibranor line rather than the obeticholic acid line. That's the one thing. The exception to the bezafibrate thing is that the combination of obeticholic acid and bezafibrate is probably the most effective of all the treatments we have at the moment. So the situation which we are using bezafibrate is together with obeticholic acid in people who aren't getting the desired result with one additional therapy. So we go 1, 2, 3, 1 Urso, 2 elafibranor or obeticholic acid, and 3 is obeticholic acid and bezafibrate. Probably obeticholic acid and elafibranor will be the ultimate treatment, probably, but we're unlikely to be able to do that for cost reasons because they're both very expensive drugs. And then the drug seladelpar will become available, we think, in 2 to 3 months. Wonderful. And will be another option, probably used in very similar ways to elafibranor. But it is good to have choices, but I am aware that this causes confusion among some clinicians. But so if you want really potent effect, it's obeticholic acid plus.
Is this in your book?
Yes. I think 3 plugs was enough.
There we go, everybody.
So if you want the highest level of control we can currently give, it's obeticholic acid and bezafibrate. If you want second line therapy, but you've got problems with itch, elafibranor is probably the way to go. They all work. You will start to hear a lot of marketing related information coming out, and I would give that a healthy amount of disregard. Particularly between seladelpar and elafibranor, they are very, very, very similar, and it will come down to if one agrees with you better. But you will hear a lot of this is better than that. Take that all with a pinch of salt.
Yeah. Okay, right. I think we've kind of answered this one. Recently diagnosed PBC, takes Urso twice a day. She's doing the intermittent fasting. Take your Urso when you want. You can take it when you want. You can take it in single doses. Take it all together. Take it with your food morning or tea time. So there's no issue there. Would you agree with that?
Can I request that if people are doing intermittent fasting, okay, do come back to the foundation and tell them whether it helps your fatigue, okay? Because I haven't got time to go into this, but to do with the way in which the body generates energy, theoretically, intermittent fasting ought to be able to help for fatigue. Now, nobody's ever really looked at this, but do come back to the foundation. Going back to what I said before, Collette said that your experience is very valuable because we put them together with other people's experiences and we spot trends.
Yeah,
so
absolutely.
Please tell us whether that whether that helps or not.
And not forgetting, notwithstanding, movement is medicine.
Movement is medicine.
Absolutely.
And the reason why movement is medicine, the reason why exercise is good, is because exercise changes the way in which your muscle generates energy. Okay, so it has a metabolic effect, and that metabolic effect is good for PBC.
It's too cold to cycle. My cycle is up on a roller in the garage. I'm in there half an hour in the morning, freezing cold. Freezing.
I know it's a tough world, but we've all been in San Diego for a week.
I don't care.
And I didn't I just say the weather's quite nice in San Diego? It was
I knew you were going to say that. Right. Okay. So we have another one of these questions. Really, the question is, should you be the doctor stop testing a gamma GT? Should you be asking it to have it with our ALP and our other tests, an ALP? She's getting an ALP, ALT done. I mean, really, you want the bilirubin, don't you? The ALP. I mean, the gamma GT, I suppose it's a handy one to have.
So gamma GT is it's useful and not useful at the same time. It's very like alkaline phosphatase for most people. So when is it useful in PBC? Well, there are some people in whom the alkaline phosphatase is normal, but the gamma GT is elevated. Is this PBC? Yes. So it is a secondary test for people whose tests are right on the edge. So does that get you to needing treatment? Yes, it would.
Alongside the AMA antibody, of course.
Yeah. So yes, of course. AMA. So AMA and alkaline phosphatase is normally enough to do it. But AMA, if the alkaline phosphatase is normal, if the gamma GT is elevated, that will also do it for me, and I would start people on treatment. The reason why we don't tend to do it is because, again, a thing in the UK is GPs are a bit obsessed with gamma GT being elevated in alcohol. Now, it's elevated in everybody with PBC. It's got nothing to do with drinking alcohol, but GPs seem to think it does. And so we've certainly come across people who've been told they're alcoholics because the gamma GT is up, as well as their alkaline phosphatase, and that's not helpful. So in fact, we don't do it. So we do it as a tiebreaker in situations when we're not sure about a diagnosis. But
wouldn't it be raised as well in fatty liver, David?
Yes, it can be, but alk phos can be as well. Okay.
Right, all right, okay.
Alk phos can be as well. So remember, your cardinal blood tests in PBC are your alkaline phosphatase and AMA to make the diagnosis, and then bilirubin is an important part of understanding the severity of it.
Okay.
But none of these tests are 100. I mean, AMA is pretty good, actually. I mean, it's 98% accurate. But alkaline phosphatase, there are reasons why it might not be up in PBC. There are reasons why it might be up in diseases other than PBC. So like all of these things, I always used to say to people in Star Trek, they can wave a sort of camera thing at your forehead and it gives you a name diagnosis. We don't have that. We have tests that give you a degree of confidence in a diagnosis. And it's why we do multiple tests, because you're looking for a panel of them. So medicine, in casualty, it's always very black and white. Everything is very clean cut. In real life, it's not. And so you always have to interpret things. It's why, well, hopefully doctors will still have a role. We won't be replaced by AI. It's because we have to interpret tests. It isn't black and white.
Yeah.
Actually, after today's performance, you probably wish I was replaced by AI, don't you?
No. I think we've done jolly well today. James Newberger phoned me yesterday. He always checks in on me. He's an absolute hoot. And I said, did you miss medicine? He said, every single day I don't. Jacqueline, I've only got one more question. I'm allowed one more, Jacqueline.
No, I'm okay. I'm all right. I'm all right.
It's full.
Yeah.
I'm reasonably new to PBC. What does Dr. Jones think of the new drug from Ipsen helping with itch? A picture attached in the latest press release, and it's Oxydivixpa, ODE, DIXIBAT. Data shows sustained improvement in severe itch and serum bile acid levels.
It says
BYLVAY, Biolevay.
Yeah.
And in brackets, ODE, DIXIBAT.
Oh, yeah, you'd expect. Yeah, okay.
You expect me to pronounce things like that? Huh?
Yes. So
I'm an accountant.
Yeah, okay. So Ipsen is one of the newer companies, just a bit of background, one of the new companies in PBC. They're really good at, they help support the foundation.
Yeah.
They're a very good company. They're very concerned about PBC and value their work in PBC. So like all the companies that we've worked with in PBC, we're very lucky. We work with them in a responsible way, but they have the best interests of patients at heart. But they are particularly good. They are particularly thoughtful about it all. They have a couple of drugs that are highly relevant. One is elafibranor, Equivo, I think is the trade name. We tend not to use trade names, okay? Yeah. So elafibranor, ELAFIBRANO, is one of these second-line treatments usable as a first-line treatment, and it does look very good in controlling PBC. It's well tolerated by people. I think it will be a drug we use a lot of. Ipsen also, the second drug, which is unpronounceable, they also have one of the what are called IBAT inhibitors. Now, these are specific treatments for itch, okay? So these are specific treatments for itch, and that's very like linerixibat, which is the drug I mentioned right at the beginning of this, which is the one that's made by GSK. So that type of drug does appear to work for itch in PBC. The trials have literally just shown that. It will not change the disease. It will, however, help control the itch. Elafibranor as a second-line treatment. So elafibranor is given to control the disease, but it will have some beneficial effects for itch. So think of, with PBC treatments, what do you need to control the disease to stop it causing you problems? And what do you need for controlling the symptoms? And if possible, combine a treatment that does both, but not at the expense of the best treatment for any of those things. So of their drugs, the IBAT inhibitor will control itch, but it won't improve the disease. Elafibranor, if you need a second line treatment, is a good drug. This is why it's quite a complicated landscape now, as we have more options. More options is brilliant because it makes it more likely there'll be treatment for any one individual patient that they can take and tolerate. But it does mean that I'm very aware that doctors are going to get confused about this. And we have a big job to simplify and explain all of this so that people don't go down a rabbit hole of getting the wrong treatments. But we are at the point of novel treatments specifically for itch to go along with the other therapies, which is a step forward. I think this will come out. I think we're going to need to do something in the bare facts to talk about all of this and the very after ASLD, the American Liver Meeting, which is where we've been, to explain what treatments, why, in what settings, and in which patients. I think that would be very useful.
David, can you do a quick fire? Because I've got some questions coming to Facebook.
Of course I can.
Yes, no, brilliant. Could vitamin B12 deficiency be the cause of fatigue in PBC?
Yes. So B12 you need B12 to make blood cells like you need folic acid. And if you're B12 deficient, then you can underproduce red cells, and obviously underproduction of red cells is a cause of fatigue. B12 deficiency per se, you do need, if your B12 is low, you do need it to be corrected, because there are other complications that come from B12 deficiency, which can cause fatigue. So yes is the short answer. But you can't replace B12 by taking tablets. So most people are B12 deficient. It's because your body can't absorb it, and actually that's an autoimmune condition of your stomach. So that's why people need injections for it. Tablets will just not be absorbed like the B12 in your diet.
They're given quarterly. Does autoimmune hepatitis ever go?
Yes, these conditions do go. Your body forgets about them. If you think about it, if you have your tetanus vaccine, then if you have tetanus vaccine, you need a booster, because without a booster, your body will forget it ever saw it. So these conditions, your body, we call it burning out, but they can burn out. However, it's pretty uncommon, and it's not something we would normally build into what we talk to people about with management. So autoimmune hepatitis, more than PBC. PBC pretty rarely burns out, if I'm honest, but autoimmune hepatitis can disappear. And there are certainly people who we take off treatment years down the line, and actually they're fine with it, although they're always at risk of it coming back again. I tend to not favour taking people off treatment, but it's something we discuss with people over, in the clinic. And there are certainly people who stop their treatment, they're happy ever after. But you do remember, every viral infection you have runs the risk of triggering it back again. So I tend to suggest they stay on a low dose of treatment. But all immune conditions can eventually burn out. Doesn't mean you're not left with the damage that was there before, but they can stop being active. Yes.
Okay. Is microcystic anemia related to PBC?
The microcytic anemia means micro is obviously Latin for small, and cytic in this situation means red cell, right? So microcytic means small red cells. B12 deficiency and folate deficiency I mentioned to you. B12 and folate deficiency give you big red cells. That's macrocytic anemia, okay? But microcytic anemia is iron deficiency. So iron deficiency in PBC can occur, and it can occur with, in particular, with celiac disease. So celiac disease, a lot of people have heard of, where you get a sort of form of food allergy, which causes irritation to the bowel wall. And about 1 in 20 PBC patients will get celiac disease. So anybody who's got microcytic anemia and PBC needs to be investigated for celiac disease, and then it's treated. There are other causes of microcytic anemia to do with any blood loss from anywhere. And obviously, it's something that GPs would always want to investigate. You need to know, somebody's got microcytic anemia, rather than just taking iron, you need to know why you've got it. So it needs an active diagnosis, because there are conditions, that everyone's aware of that can cause you to have low-grade blood loss. So it does need a diagnosis. Okay,
I have damaged my scapula 4, forward rotation. What can I take for the pain? I think you've covered pain quite a bit.
Yeah, in that situation, I would try Brufen. And if you are going to use Brufen in that situation, you are, as I said, if somebody can come up with the evidence why you're not supposed to take it with PBC, let me know, because I've never seen it.
Yeah, absolutely, yeah.
If you are going to take Brufen, you are better taking it regularly at a low dose, okay? So somebody on this call, the male on this call might have had a knee replacement earlier this year, right?
Oh, bless you, wee cotton socks.
Yeah, no, I had a knee replacement earlier this year.
Wow.
And I found that all I needed was 2 tablets of Brufen once a day in the morning. And so it didn't work so well for musculoskeletal pain if you took it when the pain was bad, but 2 tablets in the morning. I didn't need to take it another time during the day. So start with a low dose taken every day, and then build it up from there rather than reacting when the pain is bad. And you'll find it controls it much better. And try not to go for any of the more potent ones, because as we've talked about before, naproxen and things like that can have more, and Voltarol can have more in the way of side effects. But low dose brufen work to treat.
Jacqueline, can you mute your mic? It's causing interference, somebody's saying.
Sorry.
It's all right. Last question anyway. Would a diagnosis be made on a raised level of ALT and ALP alone?
So those are what we call elevated liver enzymes. And so by definition, PBC patients have raised alkaline phosphatase, and some PBC patients have a raised ALT, which is what we were talking about before. So ALT is normally elevated in autoimmune hepatitis. It's the yin and yang, as we talked about before. So it's ALT in autoimmune hepatitis, ALT-PHOS in PBC. Hence, when people with PBC also had a raised ALT, people thought it was the combination of the two, hence overlap, and that caused all the confusion. And then we realized that you can have a raised ALT with PBC as well. And so that's unpacking that we talked about before. Now, you can't diagnose PBC just on the basis of an alkaline phosphatase and an ALT. Why not? Because there are about 100 other liver conditions that could give you that combination. So you really, to make a diagnosis of PBC, you need to have an additional bit of information. For the vast majority of people, that is an ANA. For a smaller group of people, it is one of the slightly rarer other autoantibodies, some of the anti-nuclear antibody types we see in PBC. But there are very small numbers of people who are genuinely antibody negative, and you can't make the diagnosis in that situation without a liver biopsy. It's one of the remaining reasons to do a liver biopsy. So sometimes doctors put 2 and 2 together and make 5, particularly if they've heard us talk about PBC, that you would have somebody who's got a raised alkaline phosphatase and think, you know, maybe they're the right age and gender for PBC and assume that that is PBC, but you do need to have that additional test. Now, there are some people where it's classic symptoms and classic age, classic tests, maybe 1 or 2 other tests are abnormal, and they're genuinely antibody negative. Would you do a liver biopsy in these situations? Probably not. You would try treating with urso and see the effect, and that will usually give it. It's back to our old friend clinical judgment, but be cautious about making a PBC diagnosis without one of the antibodies or a biopsy.
Absolutely. Would you believe you've got through the lot, Professor? You've got a lovely message. Many thanks for a great event. Good to see you, Collette. Just to let you know, I'm here in the background. I take helpline calls. I ask people not to phone me direct in case I'm in the middle of Princes Street and the Ninos are going behind me. So if messages are left with me, I will always call you back. David, I would very much like to have a conversation with you on the phone. You've got my number. When you've got a minute, do you fancy a ring?
Yeah,
and can I say it was a joy and a delight.
And it was a pleasure to, I only heard this morning from Mo that it was you that was doing it. I was so pleased because it's putting the band back together. And Alan, can I just say you're looking far better than you normally do? Can I just say that?
Oh, thank you. I don't know what to make of this, man, really. But it's been a joy for me. You know, I'll always be with the foundation, folks. Like I said, I take the helpline calls. I was at the volunteers conference. I made people cry. And I was quite humbled. I got a standing ovation when they asked me how it all started in my front room 30 years ago. When there were, listen, David Jones, there was no internet. Our internet was the newspapers. There was no internet. How we got known, I went to Dr. Falk and said, please, can you put our details on your leaflet? It took me ages to persuade them, and then we were away.
And collaboration on writing a grant was sitting in the pub in Berwick-on-Tweed, writing a grant.
We got £128,540. You and I together for a 3-year research program.
And just on a serious note, so that was the money that allowed us collectively to develop the PBC 40.
Absolutely.
Oh no, that was 20 years ago. I mean, probably 15 years ago.
More, okay. David, it's more. I lived down in Lothian at the time.
And one of the reasons we developed it for 2 reasons. So this is the questionnaire that many people are familiar with to look at symptoms, okay? And we developed it for 2 reasons. The first is we have to take symptoms seriously in people. And if you can't measure them or get a handle on them, people don't take them seriously. It allows doctors just to ask about alkaline phosphatase, and that misses the whole point, or a big point in the disease. And then the other is, the moment you can measure something, you can measure change in something, and you can look at treatments that can help it. And so unless you've got the tools to measure symptoms, you can't develop treatments to improve those symptoms. And so it was a way of accelerating symptomatic treatment. And that goes all the way forward to what we said before about the GSK drug, and the way in which the GSK drug has been shown to improve itch in PBC patients is through the PBC 40. So all that work that started in the pub in Berwick-on-Tweed, and all of those times, that was the reason to do it, because it allowed people to focus on symptoms, allowed people to develop treatments for them, and it allowed people to show that they worked, so that people can get them in the clinic. And that takes us right the way to 2024 and the outcome of that trial. And that's where research makes a difference. And you've got to think of all the things that you need to do along the line. I was talking to the GSK people, and this is a credit to Anne Jacobi, who you'll know, and Oliver James, and all the various people who are involved in that, as well as us. But all of the people who do these, develop these measures, they are astonished that 15 years down the line, it is still as valid as it ever was, and has never been improved on. And they said they've never come across that before, that things evolve over time, but this still absolutely nails the experience of PBC patients. And I think that's the credit to Anne and people like, and who developed it. They did such a very good job, and we could only do that very good job because Collette got the money, and they got the money from the National Lottery. So when you go and buy a National Lottery ticket, one of the good causes that the National Lottery funded was the development of the PBC 40, which allowed us to measure the symptoms in the clinic and allowed us to develop a treatment. That treatment will be available in the NHS. So thank you to the National Lottery.
Absolutely. I'm a bit concerned, actually. I've just flipped over to my big screen. It says, watching from the US. Hi from the US. And thank you very much. David's second book was very helpful to me. Diagnosed last year with PBC. Lord of the third edition today. Many thanks, which is lovely. But there's another comment, and I can't. It says, "Great to watch my very first time. Informative. Hope my question makes it next time. Many thanks, Janet." Ooh. So I'm a bit puzzled by that, because normally, well, maybe not all the questions.
Just a comment. I mean, thank you for the very kind words about the book. It was written to help people, right? And the history of it is that I'd always meant to write a book, because I think people like books. I'm old-fashioned. I think people like to have something. A number of people who come into the clinic with lots of post-it notes in it about things they've read. That's how people, web pages are ephemeral. You can't find them again. That was the reason to do it. And it was during lockdown when, I didn't learn. I always say people didn't learn how to bake banana bread or play the flute like other people do. I finally got down to do it. One of the extraordinary things is that we've had to do a third edition because it has changed so fast. And this is a credit to, the foundation and Robert and everybody and myself and all of my colleagues in this, is there has been so much progress in this disease in 4 years that we've had to keep updating it. And I think we sometimes forget the rate of progress. I mean, it goes back to the 5 drugs. When I started in PBC, we had no drugs. We didn't even have Urso. And I think the rate of progress, particularly in the last 10 years, and then of that, particularly in the last 5 years, is off the scale. And the one thing that we've all got to remember is that these things are only useful if they get out to people in the real world. And I think this is where the foundation is so important, and all of you listening are so important. Don't let your doctors get away with not giving you the right treatments, okay? And they may not know, but that you can point them in the direction of the foundation. You can tell them, and you can play your part in making sure that the doctors are aware of what's out there. Where there is rapid progress in medicine, sometimes it takes clinicians a while to catch up. So it is a concern of ours that people in centres that think about this all the time are going to get lots of these treatments very quickly, and that's brilliant for people in those clinics, but we don't want people to be left behind. Would you agree with that, Collette?
100%, absolutely. And you know, it's okay that the doctors might not know very much about PBC, but what is important is they know where they can get the information from.
That's right. And I think one of the things that I mean, this is in danger of turning into a PBC Foundation loving, but one of the things that we do say is that the internet is the Wild West, and there is varying quality of information on the internet, and you can get a little bit of quackery and, you know, odd treatments and things like that. So just be aware of where you can absolutely trust. And there are 3 or 4 unimpeachable sources on PBC, but the foundation is the number one. And that's because every single fact that goes out there comes through the medical advisory board, who are the people who really care about, you know, the clinicians who really care about.
They're well experienced. You're all highly experienced, knowledgeable PBC experts. And you know, I actually say to people on the telephone, if I catch you on the internet, I'll cut your fingers off. Stick with the PBC Foundation. You have more than 5 years to live.
It is absolutely, utterly cutting edge. And it is, and that can be, you know, the foundation on the internet, but the bare facts is a great source of information. So it has probably the most up-to-date series of bits of text on PBC of anything in the world, because we write it, you know, right at the deadlines, and we pick topics that are utterly, you know, up to date. On that note, I mean, anybody ever has things you'd like to have covered in the bare facts that we haven't covered, then just get in touch.
Absolutely.
But we do this, happily do this, but it does allow us to do really bang up to date stuff. So that's, the bare facts is always a good place to look for it, because it is cutting edge.
Brilliant. David, you're a legend. The 2 of us are legends. Jacqueline's too young. Jacqueline, thank you for being with us. Thank you, David. So don't forget to phone me. It's important, okay?
Yes. Thank you so much.
I will do.
And
I will do.
Janet, I've taken a copy of your name. We'll find your question and make sure it's on next week's. But
yes, please do.
So much.
Please do. I'll be back. I do about one of these a month or something like that. So I don't know when the next one is. I just do what I'm told on any particular day. But
I'm delighted to have been asked to do
and please do come and listen to all of the experts. We all have a different take on this, which I think is really interesting. And I think that is useful for people to hear. We all have our own little kind of things we've noticed or heard, or tricks and things like that. So you'll get very subtly the core things about when to have second line treatment and all of that will be the same, but you'll get a different worldview from people. And I think and there are some really great, you know, interesting people with a very different worldview on this, which is brilliant. You know, people like Bob Gish, you know, I can listen to all day long because he is so thoughtful. So I'm not naming names, but please do come to these with different people, because they all have something to add.
They absolutely do. David, a joy. Jacqueline, thank you. Bye, everybody. David, phone. Don't forget.
I won't. All right.
Okay, bye, everybody. Bye.
Thank you. Bye.